What do you think? Yeah. Yeah. Well, he's, I mean, he's the, I don't know what he's titled, vice president of cardiovascular.
Thanks. Done. 3 minutes.
I think you'll get energy. Yeah, good.
Yeah.
You have to figure out where those guys are on HRS. Talk to the reps. See if those, see if they can talk to their reps there. If those guys are on HRS.
That's actually good.
Right? Can we start? I think we're still waiting. People still trickling in. What time is it? Is the Zoom on? Does anyone know? It is on. Okay, good. I guess we're going to wait just a few minutes while people come in, but just as a show of hands, how many people are residents here? And how many people are in the residency program? Okay, how many people are fellows here? Okay, and how many fellows are in the cardiology program? Okay, how many GI fellows are here? Okay. And do we have any pulmonary critical care attendings? Two cardiology attendings? Medicine attendings? Very good. Okay, good. Hospitalists? Very good. Psychiatry? Very good. And family practice. Thank you.
Good morning. We would like to welcome everyone to our Department of Medicine Grand Rounds. Our speaker today is Dr. Harish Manyam, our interim chair of medicine. Dr. Manyam received his fellowship training at Case Western Reserve University Hospitals in Cleveland after graduating from the American University of the Caribbean. He is the director of our cardiovascular research and head of the atrial fibrillation center here at Erlanger, and has been a valued member of our department for a number of years. We would like to share his vision of the Department of Medicine, and hopefully it'll be a shared vision by the end of the talk and engagement with you guys as we move forward into new and exciting times. Dr. Manyam.
Well, this is going to be an interesting grand round. I did steal the time slot from Dr. Minardi, who I don't see, but I'm sure she's unhappy that I took the time slot. But I did want to introduce myself. I think most of you know who I am, and I've been here for a while, but I wanted to make sure we all got on the same path. And I think that's important because the Department of Medicine is a very big department. It's hard to coordinate the number of people that are here. So the goals of this talk are really to look at what is the Department of Medicine kind of overall, what does it encompass, what are our roles and responsibilities as members of the Department of Medicine, and then how do we hold each other accountable to doing the tasks that we should do. So I think one of the things when you just talk about accountability is this room. So in the feedback process and taking on this interim chair of medicine role, one of the things I heard from residents and fellows and actually attendings is participation and ability to come to grand rounds. So does everyone feel that's still an important topic for us to talk about?
Yes.
So, I mean, I think it's important for us to kind of vocalize some of that stuff. Part of the reason is if we want to participate in that, I think the people in this room are participating, and then the other half that's not here are not participating. And there's, I think, reasons why that happens, which we will go through. So I wanted to tell you a little bit about myself. I think people think I was born in the United States because I can speak English. I go to Murphy, North Carolina. People are like, it's amazing, you can speak English. I'm like, yeah, I can. So I was born in India and I came here when I was 10 months old. Actually grew up in a long line of farmers. So my grandparents were both farmers. Each of them had 8 and 7 kids. And on primarily my dad's side, half of them became engineers and half of them became doctors. That's kind of like a thing in India. If you don't know, a lot of Indian people, it's like, go become an engineer, go become a doctor. It's like really ingrained in you. And I don't know why no one's like, go become a farmer. That probably would have been a better idea. But for whatever reason, I grew up and I was really interested in engineering. And so I was interested in developing things that could go into the body and actually maybe cure, heart disease or cure cancer or whatever it was. But I was really interested in biomedical engineering. So I did that at Hopkins. I went to undergrad there, grew up in Flint, Michigan, which I'm pretty sure I drank a lot of the leaded water. So that may explain my behavior. But did BMA at Hopkins and interested in structural integrity. So I used to study how different properties used to best bend or not bend under stresses. That's kind of how our department is kind of now. We're kind of debating what the structural integrity of this department is. How best can we flex or unbend with the stresses that this department has to undergo? During that time when I was at Hopkins, had horrible, I think most of us kind of get into medicine because of this reason, but a horrible life event where my uncle, who was kind of the patriarch of our whole family, emigrated from India, brought kind of all these other family members to the United States, and he had multiple heart attacks, kidney transplant. It was actually at the U of M, great hospital, top 10 usually in the country. and ended up dying at U of M from a septic event that was kind of preventable, and changed my whole perspective on life and decided I want to be a doctor. And so I think that's the event that most of us kind of set up on and think we're going to become a doctor because of some reason. And that was my reason. And so hopefully everyone in this room has a reason like that, because I think that can help carry you on through all the changes in medicine that are there today. So I did go to med school in the Caribbean. It was an interesting experience. Spent about 2 years there, and then went to the rest of med school in Michigan, kind of did rotations there. Then eventually went to an internal medicine residency at Allegheny General. So I think we have some UPMC grads who went to UPMC. Allegheny General was kind of a competitor, so it's kind of our memorial in a way or whatever. But very good training program, and stayed there as chief resident. Then stayed there for cardiology fellowship, where I spent 3 more years there, and then went to Case Western for EP, where I spent 1.5 years. And I actually graduated 6 months early, then stayed there as faculty for about 2.5 years. And then I stayed there primarily as the head of lead extraction. So when I first came here, people used to say lead extraction. I'm like, we don't do lead extraction here, it's lead extraction. So in December of 15, I moved to Chattanooga. It's a very interesting move because I was not convinced I was going to move here. And the reason we ended up moving was my wife. And so that's a good reason why a lot of us move, is because our wives or spouses decide that that's where they want to live for whatever reason. And she made a decision, this is the place we're going to live. And she made that decision actually based on the partners we have in our group. So at that time, we had a recruiting dinner, and the whole division of cardiology was at that recruiting dinner. And she said, sold, after that dinner. And so from then on, I couldn't convince her to go back. So we moved to Chattanooga. And at that time, it was actually less distinct from a process standpoint than it is today, as far as the complexity of procedures we do in the cardiovascular division. And we started the cardiovascular fellowship right at that time. We have one of our faculty who is actually a graduate from there, stayed on from the first class, and now we've had multiple faculty who have matriculated and stayed on as faculty. While I was here, we have had 2 training programs, performed the subcutaneous ICD, which we did a remote training. We brought in a robot that actually operators from out the country, so people from Canada could move a joystick in Canada and move this robot so they could see our imaging and how we actually perform the procedure. And so we did that for about 1 year here. We also had a laser lead extraction program where people from out the country came here and then learned how to do laser lead extraction, and we traveled also to their sites to help them do that. We eventually developed a virtual reality simulator to actually show people how to do subcutaneous ICD implants. So it's just an Oculus glass with a program on it. People put it on, they can turn around, they see the room, they can actually understand the operation and then perform the procedure. And then, my primary interest is really remote device programming, which people say, what the heck is that? So pacemakers, defibrillators, as we try to program them, try to figure out, can we program those devices remotely and then change the programming on those devices that's also very safe in a cyber secure way. We do research trials that span ablation and devices, and this is kind of what I've been doing since I've been here. So as many of you know, I've just been really clinically busy. I think the clinical busyness comes with all of these things that I've been doing during that time. So let's talk about the Department of Medicine. So Department of Medicine has been here for a very long time. For those of you that didn't know, 1955 is when the IAM program was initially approved, and then it was approved for a 3-year program in 56. In 69, it had an initial accreditation of the program, and then UTHSC actually started formally here in 1974. So the program has put out lots of faculty, people that continue to stay in this region, continue to be part of the hospital, but don't necessarily consider themselves a part of the Department of Medicine necessarily. And so what does the Department of Medicine actually include? So these are the divisions. So I think the nomenclature, I talked to a lot of our faculty about this and taking this role, the nomenclature of the Department of Medicine is sometimes lost in divisions of cardiology, divisions of gastroenterology. And so instead of necessarily saying Department of Cardiology or the service line of cardiology, I think we have to go back to saying Department of Medicine and divisions of cardiology, GI, pulmonary critical care, et cetera. And part of that's important because we can grow to a bigger kind of point of view with all of us being on the same page rather than divisions. And so I, over time, will lean into these people who are the division chiefs, who are up on the slide, which all of them are aware of, into their divisions to continue to grow those divisions and to see how we can grow our numbers and reputation in each of those divisions. So Department of Medicine, this is our core mission: teaching, research, and patient care. So how do we do these things? So teaching can be done in a lot of ways. I think most of us think about teaching at the bedside. We're rounding, we have fellows, we have residents. How do we teach them? How do we engage them? Go through didactics, case presentation right there. Well, I think now there's a lot more different, attributes to teaching. And I think one of those is simulation. So there are a lot of different simulators that are available. We have a sim center now that I think we can engage in and figure out how we can be more participative of sim training. So sim training specifically for procedures. I think learning how to do central lines, how to do chest tubes, how to do paras, thoras, et cetera. Didactics. So currently, a lot of the didactics are faculty presenting. In some cases, the residents and fellows are presenting case conferences. And I think we have to figure out a way for didactics to be with more people involved, specifically grand rounds. So one of the things when we looked at grand rounds and tried to figure out why do we have about 50% of the room full when really there's 94 people that should be here? Well, part of the reason is at 8 a.m., it's kind of the start time in the hospital, right? And so when you think about how UT operates and the hospital operates, they don't operate independently of each other. So even though you guys are residents and in training, patients still need care, patients still need to be taken care of, people need heart caths, people need defibrillators, people need colonoscopies. So most of the proceduralists are not here at 8 a.m. because they're required to start or they're required to start clinic. And so I think we have to look through this 8 a.m. start time and figure out, is there a better start time for us to have grand rounds? So maybe as a show of hands, does anyone like 8 a.m. grand rounds? Okay. Is anyone opposed to a 7 a.m. grand rounds? Okay.
Cardiology can't go for that 7 a.m.
Right. I think there's going to be a lot of ways that we're going to have to look at how do we have grand rounds with everyone in the auditorium. I think part of that is we have 2 grand rounds a month. Those grand rounds are not really participated well. I would say not all the faculty and not all the trainees are here. And so it becomes hard to say, when do we actually do sign out? When should we make sure that everyone's participating? 5 o'clock's a problem because people may still be doing procedures. 8 o'clock's a problem because I can't say, don't go do a STEMI. So how do we figure out the handoff process earlier on those grand rounds days? So we're going to look into that process. I would say that the residents are going to have a meeting later today. And so that may be one of the points of conversation you want to talk about. But I think there's going to be another point of conversation that you'll be talking about a lot. But that is something that I would like to change. I think part of the reason is I would like more people here and to hear what is going on with the Department of Medicine. And instead of doing it twice a month, to do it once a month, so we can make sure that there's at least 12 times a year where we're meeting as a Department of Medicine. Doesn't sound like a lot, 12 times a month to meet as a Department of Medicine. And then the last thing is hands-on instruction, which we do at the bedside with procedures, specifically fellows, residents, et cetera. The second part is research. So I think a lot of the things that we do, the reason why I still am interested in medicine is because I do research. And so all of the fellows that are here know that, because the first talk that I have with them is not only to get the job done in some kind of obscure way that I give it to them, but the second thing is that research is part of being a fellow. And part of the reason is, as a fellow and then to be a cardiologist at a certain point, the buck does stop with that person. But also as a resident, if you go into primary care, if you go into being a hospitalist, if you go into pulmonary critical care, whatever subspecialty or track you choose, you will be the person, right? With the answer, right? And so as we evolve our research, right, new answers come to light. And so I think at the bedside is really where we start figuring out there's this interesting case, right? And because of this interesting case, I wonder why this bacteria is in this patient, or I wonder why this patient had a heart attack and they're only 20, right? And so those are interesting cases that we should present, right? And through that initial case presentation, we should then think through case series. Do we have more of those cases, right? So thinking about the size of our hospital and the population that we serve, from patients who are highly affluent to patients who are indigent, we have a large population base that spans socioeconomic status that really we can use good data to figure out how do we examine those patients. So I want us to elaborate more on case presentations. So there's going to be a way that we're going to do that, and I'll show you the kind of the 5-year plan. Clinical research, at least in the division of cardiology, we do a lot of clinical research. So Dr. Coyright is here. She does lots of national renowned research. She's a PI on lots of trials. We do EP research specifically as also, we have tried to do drug trials here. We have not done a good job at doing that. We just don't have the great infrastructure over a long period of time. I think we should retry that, but I think it has to do with doing clinical, usually industry funded research in the beginning to supply money that can fund the research department, that we can then grow that base to then think about these other trials. The third thing is patient care. So I think all of us focus on patient care, and the question is, how do we focus on it? I think number one is you have to have good clinical acumen, right? And so that's really dependent on your training, but also on your continued medical education, which we call CME. This is a CME event, right? And so part of that is you have to continue to learn, right? So we can stay updated. And we need some kind of regular events that people are updated on the new guidelines. What is the new guidelines for the hypertension, task force, right? What are the new guidelines for ACC and STEMI, right? And so we have to have clear formatting ways that people can keep up to date. The second thing is communication skills. I think we all anticipate that we all have great communication skills, but sometimes I say things, especially in our group meetings, which we had last night. So I appreciate that, the cardiologists are here because I kept them until 8:30 last night. But communicating between professionals is very important, right? So I think in the heat of the moment, sometimes we think that, dictating things or telling people things in a way that maybe not conducive to a good relationship may be okay in a moment, but recognizing that those communication skills will span a long relationship that you will have with each other, whether or not be your colleague, a nurse, an MA, and a patient. So I think it's important for us to understand as, physicians, that we have to make sure that our communication understands the moment and spans a long period of time, and not just maybe a bad moment at that point of time. And so understanding that there will be some reporting structure, right? So if you line the division of internal medicine and you have a problem with a colleague or someone else, I would ask you to go to Dr. McCart, and so on. So there will be a clear reporting structure as far as who should report to who when they have issues. System-based practice, as a department of medicine, and for a very long time, we have been somewhat, church and state, UT and Erlanger. I'm wearing my Erlanger tie because I don't have a UT tie. But the point is that we're both. So in every hospital throughout the country, as being both, you have to function as both sides. Now, what that really means to me is that you can't think that you're on both sides. You have to just think that you're a doctor taking care of patients. And that involves quality, citizenship, and good care. So all of those things encompass you being a resident, a fellow, and attending. And so I think that's just an important concept that we have to make sure that we're not separating UT and Erlanger anymore, that we're really being consistent with, we're going to come in, we're going to work in an academic, really complex medical center, I would say, and take really good care of patients. But we're going to do it using all of these things. So this is our 5-year plan. So this is what I would like to achieve in the 5 years. So year one would be just foundational elements. So we have already started working on some clear foundational elements that have to do with the division of internal medicine. And so I'll keep on hammering those nomenclatures down for the people that I've talked to. They've heard me say that multiple times. It's important to say the division of internal medicine. In the past, we've said the Department of Internal Medicine, and then only included the division of internal medicine in that conversation, right? So division of internal medicine is, raise your hands, hospitalist attendings, academic internal medicine attendings, and outpatient internal medicine attendings, okay? So that's the division of internal medicine. So we're gonna work on our foundation. Year two, we're gonna expand our regional knowledge. I think just being location-wise where we are and not being an area of expertise regionally means that we haven't really done very much to draw people in. And so I do think we have to start drawing people in through this regional knowledge. Year three, I would like us to achieve national recognition. Year four, be a thought leader in a category. And then year five, be a premier location for medicine. And so I think when we think about a lot of people who come through, their goal is to start developing some philanthropic mission to raise money, okay? I don't want to raise any money for us, okay? I do want to do it, but we have to prove that we can do something that's foundational and element before we go to year five, right? And this is the pathway to go from 0 to 5. So year one, building the Department of Medicine. It really exists in nomenclature with divisions that really represent service lines. I think all of us know that, right? So I think sometimes the nomenclature is lost where people may say the Department of Cardiology, right? And then we exist as the Heart and Lung Institute in Erlanger. And then we function as a cardiovascular division because the pulmonary critical care division separates differently. So that nomenclature is really lost in figuring out who am I part of, right? And so understanding that we all fall within the Department of Medicine is a really core concept, because as people need things, Department of Medicine is actually the biggest department in the hospital. We just don't function that way in the hospital. So figuring out a way to function more appropriately in the hospital and through UT will help envision this Department of Medicine. I think the next thing is really bridging this gap between transparency, responsibility, and accountability. I think it's been hard to develop transparency. And so that's going to be very, very important for me to make sure that everyone understands what we're doing, why we're doing it, and the reasons behind it, and to have really open meetings. So our cardiovascular division meeting is really open. I mean, people ask questions. Mark was there last night, so the fellows can ask questions, attendees can ask questions. There can be debates, love some debates, where we can talk about key core issues. So to separate the, actual grand rounds from a Department of Medicine meeting is what we will do. So there'll be different Department of Medicine kind of business meetings, I would say. So I think just as far as the Department of Medicine, it really separates into outpatient, inpatient, research, and then in totality, the expertise. So outpatient. So the outpatient has been an issue. For the residents here, have you all been happy in Dodson? They're smiling. It means yes. So I would say that your division of internal medicine faculty has been very supportive at trying to make this significantly better. And so I'm not taking, I would say I would not take credit for any of this. So I would give credit to Dean Haynes, Jensen Hyde, Nick Pamilia, Ann Minardi, Eric McCart, Curtis Carey, Natasha Amjad. So really took ownership of trying to figure out why is this such a problem? So the historical issue was that, UMA as a practice was the internal medicine clinic, and that resided in the Whitehall building. The plan for Erlanger at one point was to blow up the Whitehall building and build another building there, right? Which would be a patient tower. Where that is in the plans, I have no idea, but I don't see that happening anytime soon. But the point of that being is that the resident clinic, which was UMA, was moved to the Dodson clinic. And I've never been to Dodson, but I don't think I would ever want to go to Dodson. And so I would say most residency clinics are not necessarily don't necessarily have to be in a horrible area. to necessarily take care of indigent patients. We take care of indigent patients here all the time. Take care of indigent patients in my office, which is in the medical mall, right? So you don't need to be in Dotson to take care of indigent patients. You also have to have an experience that is not just patients who have low socioeconomic status. They should have all socioeconomic statuses, right? Because that's part of delivering care, is understanding that. And so there was a clear issue in understanding, or, why we moved to Dotson, but, clearly safety, growth, how would we grow in that area? In the clinical arena, how would we really move and transform that space? So to do that, the goal is to move the clinic. So the clinic will not reside in Dodson, hopefully by July 1st. And so there are operational elements that are happening today, hopefully, that we will move that clinic. So that experience, that location will change significantly. So I would say that there are two people in this room that will primarily be in charge of that clinic. One would be Nick Pamelia, and the other one would be Tracy Dozier. And so they will help form a clinic that will be much better, I would say, from an experience level. And from a residency standpoint, I think most people can see what it will be like to be an internal medicine attending in the office, because I think that's really a different experience than what you're having now. And so I think that would be a really positive thing. And long-term, understanding how primary care really fits in that model of internal medicine. So the next thing is bridging this gap between transparency, responsibility, and accountability. So when most people ask us, what's the game plan? What we've been doing in this interim period is having clear lines of communication. It's so important to do, especially when you have a lot of highly motivated people here, okay? I would say most people in this room are type A, okay? And so when you look at a lot of type A people, a lot of us are running in some kind of path in a direction that we see is the right direction, but sometimes we don't necessarily communicate what we're doing. And it's the problem with the lack of communication and the lack of maybe transparency in where we're all going that gets people into problems. So we more recently have made sure that the communication lines are really open. And so we're going to make sure that there's always kind of a plan. People understand what the plan is. When there's questions about the plan, people ask those questions. And that when there are problems with the plan, we can reformat the plan, okay? It is a plan. It's not, the word of anyone, it's just a plan that we're trying to make, to create, to go to a place. What are my roles, right? So everyone in this room has a role, and that role will be better defined by the division chief, okay? So the goal is that the division chief of each division will make sure that everyone in the Department of Medicine has clear roles and responsibilities. And how will I be held accountable to those roles? The division chief will be expected to hold people accountable. And so the goal of that is to really make sure that as we're trying to grow this Department of Medicine, and as I go to different division chiefs and say, how are things clinically? How are things with the training program? How are things with, research? And as we try to grow that, it'll be the responsibility from division chiefs to really make sure those things are happening. I would say that most people are doing that inherently as a function of their job. And then most of us that fall below the division chiefs don't know that we have a role or responsibility in that. And so I think it's defining those roles and responsibilities, because I think most people want to be part of that and to be helpful in moving that forward. The next thing is we really need a faculty development series that doesn't just include maybe a lecture here and there, but a real maybe retreat / faculty development series. I would like to establish that annually. And so I'm going to need help with that. I would like probably a resident fellow in at least 2 faculty to maybe take that on. And then we will work on funding to take care of that so people can go offsite for half a day. But there are a lot of things that you can learn from communication, who you are as a person, who you are as a leader. We all do things very differently. And sometimes understanding each other is important to actually working with each other. And especially as we have this huge Department of Medicine, it's important for us to understand each other. So anyone that is interested in that, I will take volunteers. Year 2, regional knowledge. So in year 2, we really want to expand how we become involved with societies. So as cardiologists, we're involved with ACC, AHA. I'm involved with Heart Rhythm Society. There's AFib societies now. So we really want to be focused in the Department of Medicine also with SHM, Society of Hospitalist Medicine, SGIM, Society of General Internal Medicine, and ACP. So Dr. Panda's not here today, but she's a leader in ACP. And so I'd like us to be more of a regional leader and thought leader in those societies here. So I've talked to people already about kind of taking ownership of becoming more involved in those societies. I think what I recognized when I was in residency and I was chief resident, I published, maybe 20 or 30 case reports during that time. And so case reports are all around you. And actually regionally, what we should opt to try to do is make this a place where we can have a regional conference for ACP or regional conference for SHM or a regional conference for SGIM. When you think about our location, proximity, ability to travel, hotels, all of those things, it's really easy to accomplish that in this region. And so I think we have the faculty, I think we have the bandwidth, and I think we can develop the expertise. So I'm going to lean into people to do that. Each of the divisions, I'll also lean in to for their societies. And I think that for the people that I will lean into, we have to develop true leadership tracks. So most of these societies do have leadership tracks that you can be part of. We have to sponsor people to be more part of that. More recently, there are different programs that you can find that are not necessarily 1 or 2 year programs. I don't necessarily know that an MBA is helpful for everyone in the room to get an MBA, but I do think that there's true leadership tracks that can help you be more successful as a division chief or department head. So year 3, national recognition, really is built on what we would have done in the last 2 years, but really making sure that we continue to work on projects that will build our name. And so the way that we would do that, after speaking with the dean a little bit, but also with administration, is really through the research that we are doing already. And so a lot of us are doing research. I do a lot of research at night. Erickson knows that because he also does a lot of the research with me at night. Part of that is important because it develops our national recognition. It's very hard to be clinically very, very active, train fellows and residents, and also spend a lot of time on database work. So what we'd like to do is actually figure out a way to get a departmental researcher, someone whose prime focus is to work on research in the department, who would not be a physician, who would be a researcher. And they would help with collating data, getting stats back to you, figuring out tables and timelines that we are due for submissions. And that would be helpful, I think, to everyone in this room to make sure that they accomplish some of the goals that they have. So if you want to figure out a retrospective review of all the people that had urethral cancer in the hospital, you have a great idea for whatever the case report that you generated, and then you need someone to help collate some of that data. This would be the person that would help you do that. As we develop faculty, we want to make sure that people go down the appropriate pathways for research, but also understand best practices of how to teach. I think that's a skill set that not necessarily everyone has been trained on. I think residents train in different ways, meaning that some of you may read a book and pick everything up. Some of you may learn better at the bedside. Some of you may think test taking is easy, and some of you may think test taking is hard. And so part of our mission should also be to figure out ways that we can develop all of the residents and fellows to understand that everyone will learn in different ways. So our teaching methodologies may have to adapt to each individual. And then the last thing is quality improvement. And I think there's a lot of quality improvement that we could look at to make UT and the hospital function and work better. And I would say one of the key concepts that I think is just a thorn in the side always is transition of care. And so transition of care specifically has to do with sign-outs. Originally when I was chief resident, it had to do with when do you sign out? Why do we sign out? What should we sign out? Why is it important to sign out, right? And so that transition of care is important because that team member has no knowledge of that patient. Well, that happens in the real world. So when we see patients in the hospital, that information doesn't always translate to the internal medicine attending that's seeing the patient in the office. With Epic, we've done a better job at making that transition easier because all of our notes are there. But that visit takes a longer amount of time. And then not all of those patients have appropriate access to, physicians or APPs in the office because we don't have enough touch points. And so we have to work at transition of care models. And I would say not only in the patients that are residing in our emergency room, but also patients that have, I would say, subacute issues that can be taken care of in the office. So an example of that in my mind would be AFib. Someone who shows up with AFib in the emergency room, it's not someone who we have to put on, at least when I was training, heparin and then transition them to Coumadin and then rate control them for a week. It's someone that we should think about giving them a DOAC, giving them a beta blocker, making sure their echo is fine at that initial visit, labs, and then send them home. And that should happen within 12 to 24 hours. And the patient can then follow up in the office within a week. That frees up a bed in the hospital, and it helps with our length of stays. It helps with us taking care of sicker patients in the hospital, and it helps with that transition out. So we're going to work with each of the divisions on transition of care models so we can help with getting patients the appropriate care that they need. Year 4, just to engage in being a thought leader, this will be developed based on the first 3 years and really figuring out of those programs that we're trying to develop, which one do we find that we have become a thought leader on. And then year 5 is really a premier location for medicine. So I think when we think about premier location for medicine and we think about we are University of Tennessee, I think we have to decide who we are. And so as we talk through, are we Erlanger, are we University of Tennessee, we're all of the above, So the reality is understanding that that is a commitment to deliver care in the highest way and figuring out ways that we continue to do that and engage with people outside of this building as well to develop that Department of Medicine will help us get to this. So how do we make this transformation? It's really a big ask, I would say, because I'm asking people to work a little bit differently and think a little bit differently, but it has to come with a patient's first attitude. I think a lot of people in our group say, what would you want for your mother? What would you want for your family? But I think what we're really trying to say is, let's take care of the patient first with the patient first attitude. How do we engage the patient? How do we make sure that they're involved in decision-making? How do we make sure that the core concepts of taking care of them are good? And so I think all of the things we're talking about have to do with these transparency, responsibility, and accountability. And so that's important because if we really want to take care of our patients, like they're our family member, or that we're going to take care of them first, it means that our partners, which is everyone else in this room, has to do their job really well too. So if I come to round on cardiology at 3 p.m. and the Division of Internal Medicine consulted me on a patient that they're trying to discharge, well, they don't discharge the patient till the next day. And so that ends up with a STEMI that can't come into the hospital. And so that affects all of us. And we have to think more globally how we're affecting each other in this model, because we all do it every day. We just don't do it purposefully. We do it accidentally. So transparency and understanding what we're doing and why we're doing that. So the next thing is really also not only giving patients great care, but I do think we have to start thinking more globally. How do we prevent patients from getting disease? I think we're all acute care providers at this point. But I think really in the future, we have to think about how do we prevent patients from getting disease? Are we talking to them about lifestyle modification? Are we talking to them about smoking cessation enough? Do we have programs that enable them to think about diet and exercise? And so that's something that we also have to develop to make sure that we're taking care of patients. The reality is the acute care hospital will not be here in this form in 10 years. And so we have to keep more people at home in the future. And then how do we do that? Discuss these problems openly for transparency, create a model that all of our faculty can grow and understand the whys behind decisions. There's always going to be tough decisions. I think there's going to be plenty of times where people are not going to agree, but we have to understand that there has to be some decisions and we move forward, and that there has to be a why. And then we have to help patients make informed decisions from transparency. Accountability, roles and responsibilities. We have to create a path of what we all expect, which, as I said, we will leave to the division chiefs, and then have individual discussions with each faculty member to make sure that we're having progression. I think a lot of us can continue working for 5 years and then look back at 5 years and said, wow, that went by fast. And what did I do during those 5 years? Did I do, the 10 things I said I was going to do? And so we do biannual reviews. Part of it is to make sure that, as people are doing diagnostic studies, if you happen to be an echo reader and reading echoes all day, if you read echoes every day, or you're doing some task every day, that may be 5 years that you go by and realize that, I didn't do this other thing that I want to do, this other research project, or get this funding that I wanted to do. And so this will be a good way to make sure that people are on the tracks that they want to be on. And I think, the key is culture. It has to be not just individual or division-based or numbers-based, that we really need to merge all of these together and think about quality, numbers, and division into a department. And so in the future, Department of Medicine faculty meetings like to include all of these concepts as a presentation, and how really the divisions grow through research. We've had long discussions, at least through the division chiefs since I've been here, with research money. And research money, there is research money that comes into the institution through clinical trials. We have not seen or used any of that money, but that money could be used for purposes that are, either growing the department, growing the research monies, doing something that I think can engage more people in what we're doing. And then I think if we help this, then the department grows through a stronger overall goal. So near term, moves, the clinic in Dotson, we would like to move that clinic. So we're working operationally to make that happen. I think Dr. Pamelia is having a meeting today at noon with the residents, so you guys can talk through this a little bit more. The nomenclature, we talk about, Heart and Lung Institute and Division of GI. I think we have to start utilizing the nomenclature Department of Medicine more to really understand how many people are there. Our communication, making sure that lines of communication are open between faculty, residents, nurses, MAs, and then make sure that we have a faculty development series that I think is offsite that can engage people and do that annually. So grand rounds, I did say 7 a.m. I saw some naysayers in the crowd. So operationally, I want to see how that works. But what I'll do, at least first, is send out a survey monkey. I'll try to do that by the end of the week to see what people's suggestions are. The key is for us to have the vast majority of people here. And so if we really want to be a Department of Medicine, it has to do with participation. I can't go to my daughter's graduation if I'm not there, right? You can't participate in your daughter's graduation if you're not there. So you have to be present, and so I want to make sure we have a time that is conducive for everyone to be present. If we change it to once a month, the ask is once a month. So I want everyone to keep that concept in mind when they're doing their survey monkey. I'm going to engage with more key stakeholders often to figure out where we are, what we're doing, where we're going, and at least held these faculty development series once a year, but also once a month to have faculty department meetings. And so this is a Department of Medicine meeting that I'd like to change to once a month. And then near-term changes that are working on now has specifically to do with the Division of Internal Medicine. So Dr. McCart can communicate that to the rest of the division as we make changes. Any questions? Start with Dr. Coyle right here.
Thank you for opening up the conversation about the vision for the next 5 years. And knowing you know that you want that to be a collaborative process where we have engagement across. And I think one of the things I heard you say is, you know, we really want to develop into a leader. And we can't be a leader in all things. And I think what we really specialize in here are treating the most vulnerable patients. And I think that's a measure of our greatness. How we treat our most vulnerable patients is really the measure of the value of what we offer. And so I might add that a continual focus on diversity, equity, and inclusion across all that we do, whether it be in our teaching, in our research, in the way that we treat patients, and in the representation of our leadership in the Department of Medicine. I think it's something that we should take a look at together. We want to reflect the community in which we serve and make sure that that's front and center. And I know that you're passionate about that. And the thing I note being here just for over 2 years now is, boy, does that have to be a vision across all of our areas in order for us to have an impact. And I'm really excited about that as part of the 5-year plan. What are your thoughts about how that might merge into what you presented today?
Yeah, I think, you know, when we think about that globally, at least diversity, inclusion, and taking care of really vulnerable patients, I think we do that in the hospital, but we don't do that necessarily with intent. And so I think what you're saying is, let's think about that more with intent rather than just do it ad hoc. And so I think as part of a member being part of the Diversity Council, there's more of a global focus from Erlanger thinking about that with intent. So I think that's helpful, and to merge that with a UT side would be good.
I'm Andrew, I'm a 4th year med student. Really excited about this, wish I'd be here to see it. One thing I want to suggest is maybe we also include a plan for medical student PA students in the Department of Internal Medicine.
It's great. Yeah.
I can tell you, it's been fantastic. I've loved it. What I would like to humbly suggest is we can get some more involvement of medical students in the various divisions. So when I was doing my 3rd year clerkship, I remember there was a time I was interested in cardiology, but I didn't know how to reach out to anyone in the division to get some more experience. And so maybe what we could do is have a volunteer in each division that is in charge of medical student, PA student incorporation. We can make a list, have a contact thing, give them to each clerk as they come in and say, hey, if you want to experience more of a division, this is a person in that division you can reach out to. Each one of us is a chance for this department to recruit some talented students, and we don't want to pass that up. This could be a way we can improve that.
Yeah, that's great feedback. You know, I'll tell you, interestingly enough, I don't interact with medical students. I would say it's very rare for us to see medical students. And I would also say it is very odd in our sense, because I think most of our faculty are really interested in teaching. And so we would love to have medical students in the cardiovascular division. So that's an interesting concept. We can talk more about how we work with the medical students to figure out what their interests are. You know, historically, at least from my standpoint, I almost became a trauma surgeon. Not many people know that. And then I looked around, and don't tell the trauma surgeons this, but I was like, I can't be a trauma surgeon if this is how they are. They were all just upset all the time. I was like, I'm a pretty happy person. So I ended up becoming, I went into internal medicine because I really enjoyed cardiology as a field, but it was because I had the option of talking to clerkship directors and then them asking, hey, why don't you look at this? And then seeing that as a subspecialty to figure out a different path very late in the game plan. And I ended up changing my residency because of that. So it's a pretty big move, and I would say it worked out really well. So I do think it's important for people to understand different subspecialties, specialties, and tracks early on, so that way you can figure out what you would really want to do. So I appreciate the feedback. Anything else? Okay, Survey Monkey to everyone. Thank you.